Good morning. Okay, good morning. I am for you today for speech to give of this problem of sex and a problem for maybe for 1 hour or so something we speak. This, just kidding by the way, if you don't know me, that kind of thing, right? So, in any event, I just came back from Europe, and it's actually, we're really spoiled because when I go to conferences, the official language is in English. And of course, that's the problem. The official language is in English. So I hear things like mechanical ventilation. I'm going, mechanical. Okay, I got it. I shouldn't make fun because I actually have attempted out of courtesy to try to speak other people's languages, and I've actually been banned from 7 countries from using their language, okay, that kind of thing. So here we go. First of all, I wanted to thank everyone for having us here today. It's really our honor and privilege here. And then I found out something. I found out why I got invited. Apparently, NAEMT has a special clause in there that you're used to having like really attractive, charismatic celebrities speak to you. But apparently, there's a rule that every once in a while they have to have people, let's say, who are aesthetically challenged, that kind of thing. So I remember someone said before I was a giant. Yeah, right. Okay, but in any event, the other thing, Eddie, chief, I like where they put senior fire chief, okay? So he's like the fire chief, okay? Then I saw senior, I realized that you got your AARP card, right? So that was pretty cool, Eddie, good job. So that kind of thing. So that's probably why he's the senior fire chief, okay, that kind of thing. Or he's actually been here for more than 2 years or something like that. That's it. So good, thank you. And I'm actually, let me do that and mention about the Dallas Fire Rescue, which I'm very, very proud to be associated with them and their partnership. They have what we call the Biotel system, which is it's about 20 cities in the area. They're not suburbs. I mean, Irving is larger than a lot of large cities in the United States, for example. But it's a terrific coalition that they have founded here that I inherited. And they working together has done tremendous things, particularly in the area of resuscitation research. With the NIH coming in here, some of the work they've done, literally, we were hoping to increase survival rates by 10 or 20% with some of the studies we're doing. And Dallas, over the last few years, with a lot of hard work from those firefighters out there, and I mean the firefighters, not just the paramedics, everyone out there, has increased their survival rates more than almost 60% over the last few years. And in some of our smaller towns like Carrollton, they've increased the survival rates by 4-fold. And it's just from hard work, practice, redoing it, and it really has made a terrific difference for dozens and dozens of families in this area. So thank you so much. And thank all of you out there for what you do on a day-to-day basis. It's not just the life-saving thing, the fact that you're there providing not management or treatment, but care for the people. And thank you for caring for them on a day-to-day basis. We know that 90% of what you go out to probably doesn't require a lot of advanced skills. What it requires is human skills, and you have it better than I've never met a more dedicated group of people in my life, and that's why I've dedicated my life to EMS, and I'm really grateful to be here and all that. So, okay, thank you. So, now we're going to get into some real serious stuff, okay? So we're supposed to talk about, when I was younger, I used to play rock and roll, that kind of thing, and we were into sex and drugs and R&R. Well, now it's resuscitation and reanimation and all that. So, so let's see if we have a little clicker here. So, yep, here's one in my pocket here. So let's start off with this. I just want to start to give, you have this thing that says sex, drugs, and all that. So you probably have a preconceived notion what this is all about. And we just wanted to show you something that will get you straightened out here. It says the patient has a fractured fibula. It's on a mild sedative and probably can go home tomorrow. If you can hit it, please. Thank you.
Patient has a fractured fibula, given a mild sedative. So he can be able to go home tomorrow.
Daddy's going to be so excited.
That killed him.
Dr. Palmer, Dr. Barbara Palmer, dial 45.
Okay, so don't judge too quickly is all I'm getting at here, okay? So let's move on. Not to bury the headline, we're going to talk about something you may be doing in 5 years or 10 years, because there's probably a part of your evaluation that says, is this applicable to your practice? Well, it won't be today, but it may be in 10 years based on what we're going to try to tell you about today. We're trying to give you a heads up. What we're going to say is that estrogen infusion, okay, is safe, it's inexpensive, and easy to use. And that's why you see it there with a single dose in the back of an ambulance. and has a high probability of efficacious effect, as we're about to show you here as we get through this today. So to start the story off, I want to tell you about, we were asked to do a dog and pony show here today, and you guys know who the dog is, okay? And I want to introduce you to the pony over here, Dr. Jane Wigginton. Got to get past the speaker so it doesn't feedback. So Dr. Wigginton, as you heard, is a really interesting person. She was actually in business, was very well-to-do, and decided to volunteer down at Parkland Hospital, and probably just an excuse to get away from the 5 kids she had at that time. And that's why we call her Trauma Mama today. She's got 6 of them. But in any event, she wanted to volunteer, and she was really impressed to see what people were doing down there at our trauma center. So, in any event, what Jane did was decide that here she is on in life there for a while, and she said, I'd like to go to medical school. So she goes pre-med stuff, goes to medical school. When we start our residency program in emergency medicine, she goes up and decides that she's going to get into that. She became our first chief resident. And about that time, she had an interesting question. The interesting question was to actually examine whether or not women had better outcomes with heart attack. As we found at that time was that we have had data that said women had worse outcomes, right? What have you heard? I mean, when they have heart attacks, they're supposed to do worse. But some people raised the question whether or not that was mostly sociological, like they had different symptoms, or maybe they didn't get as aggressive a therapy as men did. So there was an interesting question, and Jane decided to come up with a very clever way of doing that, and we'll see how that works out, okay? So we're going to work up on the stage for practical purposes here so that you can see us. So in any event, let's go ahead and move around here, and I'll bring Jane up. So here's the background on this, if I can. I want you to know is that just to fast forward today, Jane is really on the short list of kind of research, cutting-edge research that the National Institutes of Health is doing. So here's a person who basically saw some cool things going on in medicine, said, I want to do this, and has really done terrific things for us, as you'll see in some of her research she's done. So with that, Jane, can you go ahead and take away the background and some of this? And please welcome Dr. Jane Wigginton with us here today.
Thank you all so much. I'm so excited to be here. So anyway, to bring everybody in this room up to speed, I want to let you know that over the past 30 years or so, there has been an incredible growing interest of the differences between the sexes, between men and women. There have been numerous differences that have been observed by trauma specialists in cases of hemorrhage, cases of head injury, stroke, sepsis, in the way that women respond to the injury, and also treatments. These differences have been so profound that actually Merriam-Webster's dictionary has decided to start putting in 2 definitions for words, one for men and one for women. Paul, can you give us an example?
Well, a classic one, of course, is the remote control, right? Remote control, that kind of thing. So, for example, it says in the dictionary for women, a device used for the purpose of changing from one television channel to another. For men, okay, well, it's, a device used for scanning through all 275 channels every 2.5 minutes, et cetera, kind of thing, right? So that's just one example. Jane, you are more close to the next one. For example,
oh, yeah, absolutely. I'm going to give you my favorite one. This is personal communication, which for women is the open sharing of thoughts and feelings with one's partner. But for men, it's sticking a goodbye note on the refrigerator before leaving on a spur-of-the-moment hunting trip. So you can see that there are profound differences between men and women. But in all actuality, to get back to the seriousness of this, as Dr. Pepe mentioned earlier, are there really gender differences in cardiac disease? There are numerous.
That was a trick. I just wanted to trick you. That's all. Thank you.
Are you checking to see if I know the next
I want to see
slide?
if you're paying attention. That's all. So, okay.
There are numerous articles that are out there that say that women do worse following MIs and things like that, like unstable angina. And as Paul mentioned earlier, the question is it sociological? Is it that they have different symptoms that aren't recognized? Is it that they get different treatment? And it was very hard to ferret this out. So we thought, gosh, there's an opportunity to do a really cool study about this. Because what about cardiac arrest? This is an instance where the diagnosis is very clear. Someone drops dead in front of you, and they get the same treatment based on the AHA-ALS guidelines or BLS guidelines. They get the same treatment. So Paul, what do you think about this?
Well, obviously, I thought this is a very cool concept, and Jane actually approached me about this, and she wanted to do a study where she would look at people and observe to see if there were differences, not only in terms of the presentation, but in terms of the outcomes of women. And we thought this is a great concept because the majority of them do have underlying coronary artery disease. So if we can track them and see what happens with them, not only do they present with differently, but what's their outcomes? Are they different if you compare them? And that was the first aspect of this was published in Critical Care Medicine back in 2002, and there were some preliminary results at that time. The findings of that original study are very interesting. First of all, just to give you an idea, there were 10,000 patients that we studied. That's a huge study. And it really tells you a lot of great work that she did capturing all this data, et cetera. And there were significant presentation differences. What do you think they would be? Well, first of all, the women were significantly older. On the average, when I first got into this business, it was 59 for the men and about, something like 67 for the women for the average age of their cardiac arrest. Today, we're looking at more like 62 and 69 because people are living longer. But 69 years old, okay, it was the average age for women. So they were significantly older than men who are at 62. And so that puts them at what? An advantage or a disadvantage? Clearly a disadvantage because they're going to have some other, perhaps comorbidities, as we call them, other problems they did at that age. They're 70 just about. What they also had was much less VF. And which is the most, if you have a presenting rhythm, asystole, VF, what's going to be the more reversible process? Obviously, VF is pretty fresh, and it's less of an ischemic insult that's going on, so you figure if you have less of that, again, the deck's stacked against you in terms of age, in terms of the presenting scenario, et cetera. So here's an interesting, we found no differences in terms of the witness status. They were witnessed just as often, bystander CPR, response intervals, and pre-hospital ALS times. And I want to drive that home because, in fact, what we found here, the Dallas Fire Department was the primary group that we studied here. And what was really amazing is that they really did give women and men exactly the same theory. If you looked at practice or treatment. So, for example, if you had an asystole presentation, everybody got the same percentage of drugs. Everybody got the same number of shocks for VF. For example, let me give this. The pre-hospital ALS interview, the time that they spent responding on scene and to the hospital was exactly, completely duplicated. It was basically, so we did prove Jane's original theory that this is a specific thing that is pretty easy to identify, and they would get the same treatment therapies. And so they're pretty even on this. So that was very cool stuff to find out. So what's the survival? Now back then, we're going to present to you just how well they did in terms of getting to the hospital alive and admitted to the ICU, because those were the data that were available 10 years ago. We are going to come out with some interesting information here in just very shortly, but you can extrapolate. If you get to the hospital, you tend to make it out of the hospital. So this will give you an idea. But to keep apples and apples comparison, we're going to show you what it's like to get short-term survival admitted to the ICU. And it turned out that the women had better outcomes. The women had better outcomes. So that's interesting. So first of all, that goes against what we had seen in other studies previously. And for those of you who don't know what a p-value is, it has nothing to do with going to the toilet. This is something else, okay? The p-value is the probability of something happening just by chance. And when you have a statistic that says p equals 0.001, that means the chances of this just occurring by accident in this study was about 1 in 1,000. So it was like 999 to 1 that this basically was just, this is the real deal. And that's pretty good statistics, by the way. We accept 1 out of 20 chance, okay? So what are the implications of this? Is this a surrogate variable for another factor? In other words, that the women did better. For example, is it their chest wall compliance? You know, because pumping is so important. So is it because they have different chest wall configurations or anatomy? Is that what it is? Or is it genetic differences in response to ischemia or response to therapies? There's actually some underlying stuff for that. And for example, there's a thing called pharmacobiology. So what's pharmacobiology, Jane?
Well, pharmacobiology is the way that different groups of people respond to different drugs. So, for example, the way that men respond differently than women. And it's been shown time and time again that women do respond differently. For example, from general anesthesia, women wake up minutes earlier than their male counterparts. but also in drugs like antihypertensive drugs, antidepressants, DIG. And you guys out there know, if you give a female the same amount of alcohol per kilo, she's going to get drunker than you are. And it's just a fact that women get drunker off the same, okay, that women get drunker kilo per amount of alcohol than their male counterparts.
So, okay, well, whatever. Okay, so, but...
Or Paul, is it just genetics?
What are you doing tonight?
Drinking? No. So, is it just genetics, Paul, though? Is it just that little Y chromosome?
Well, that's an interesting point because, actually in many cells in the body, the X chromosome just shuts off in the women, so they just operate off of one of their X's. So the difference really has to lie in that Y chromosome. So we actually did some sidebar work, and Jane did some terrific work in revealing some things. And if you don't mind, can I tell your story and what you found?
I'd love for you to share it.
Okay, good. So what she did was she did a mapping of the Y chromosome. And what's interesting is that right away you find the TDF locus, which is a spot on the gene that is the testis determining factor. But there's some other really interesting things that make a difference. For example, there's the Godfather 1 and 2 appreciation zone, also known as the CQF locus. That's the Corleone quotation factor, okay, that kind of thing. There are things like fiddling with gadgetry, the MAC locus, and there's things like, channel flipping factors and air guitar and sports pages and all that kind of stuff. And of course, the ones that I have a high penetrance on, so to speak, is the selective hearing loss, that kind of thing. Like my wife was telling me the other day something about, I don't know what it was about. She was saying I don't listen to her, so I don't know, I wasn't really paying attention, that kind of thing. But the real big one for most of us men in the room is of course, the OOPS locus, total loss of recall for important dates, okay, that kind of thing, right? So that kind of thing. Well, but anyways, so the question is it good genes or is it good hormones? What do you think about that one, Jane?
Well, it was an interesting question because we know that at the time of their cardiac arrest, most of these women who had cardiac arrest were postmenopausal. And we thought, wow, is there a way that we can separate out these two groups? Because the average age of menopause in US women is the age of 50. So we thought, wow, let's separate these women out into two groups. Those who are presumed premenopausal and still under the influence of hormones, or those under the age of 50, we call them younger, versus those who are presumed postmenopausal who are over the age of 50, and we call them older, so younger versus older women.
Because at first, right, we weren't thinking that it was hormones, because if their average age was 69 plus or minus whatever, it couldn't be. The good news is Dr. Wigginton did such a terrific study. When you got 10,000 patients, you can get a lot of data. So when we did follow this up, and when we checked it out, the total number of patients, again, of the 10,000, there were actually 839 younger women, that is under 50, and 1,600 younger men. So it gave us now a little bit of statistical power to be able to examine this. So it'd been a terrific thing that she did. So here's the deal. The survival, women versus men, interestingly enough, it was a pronounced difference in those under 50. The survival rate was 28% for the women and 17% for the men. And again, this says less than p-value of 1. I mean, this is like, the numbers were like from here to there and back again. It was like really impressive in terms of saying this is a profound difference that we were finding here, okay? And if you look at something like VF, right, where remember women presented less often with VF, but when they did have VF and you compare it to the men, the survival rate was almost double. And again, the statistical significance of this was just incredibly powerful, et cetera, when you look at this. But if you think that's profound, wait till you see what happens here. Almost all the differences between the men and women of all ages was explained by that subgroup of childbearing age, those who presumably have a lot of hormone floating around. So for example, if you look at the older group of men and women with PEA, electromechanical dissociation, pulses, electrical activity, the survival rates were essentially matched, 18 and 19%. Well, so were the younger men. They ballparked right in the same area, but look what happened with the women. They had a 50% better chance of going home, and explained almost all the differences between the men and women were completely explained by the subgroup who was under 50 years of age. That's pretty impressive stuff. And you take a look at asystole, okay? Now, what makes PEA and asystole different from the VF numbers? What's impressive about that is these are presumably in most situations, a more anoxic insult. In other words, it's a more severe insult without having oxygen. Because VF is relatively fresh. Once we get there, a lot of the VF has gone down into asystole. We know they've been down for a long time. And look at this. If you look at asystole survival, we had 10% for the men and women, and guess what? Double the chance of survival if you were basically under 50 years of age. So this is pretty profound stuff, and it really is interesting. But there's a problem with our data, because, right? What's that, Jane?
There are some limitations, and those would include the fact that we didn't actually measure the hormone levels in these patients. We just put them into categories and presumed their hormonal status. And we also didn't know if they were maybe taking birth control pills or hormone replacement therapy, something, an exogenous drug or exogenous hormone.
Hit the wrong button again. Sorry about that.
That's okay.
So let's see if I can turn
We'll
this
just
back
make
on.
hand shadows. No.
Okay, good.
And also, the long-term outcome and neurostatus hadn't been studied yet at that time.
Right, exactly. But the thing of it is, the good news, that was the emphasis is on the not yet part. In a study that actually I participated in, we recently published back in Critical Care back in May, we actually looked at this. It was a corresponding in-hospital study. Based on Jane's original work, we have a thing called the National Registry of CPR in all these different hospitals around the country. So we decided to look at that and see what did we find. And guess what? In this study, we were able to put together 95,000 patients, almost 100,000 patients. And what we found in that study, actually, was that women of childbearing age have better in-hospital cardiac arrest survival rates than equal-aged men. And I won't go through the data too much, but the bottom line is that they did much better neurologically, and so we proved that, again, there's protective effects in that area as well. So what about serious head injury as well? I mean, I just talked about cardiac arrest, but we inferred to you that there were some other issues in other areas. And one of the things that troubles us out there in the real world is not only is cardiac arrest our #1 killer, but another one of our big killers, particularly of our young adults under 45 and children, is basically trauma. And most of them are seriously hurt long-term and permanently from head injury if they're not killed outright. So an interesting thing came up in the area of head injury, and I thought, Jane, since you did the work, I thought we ought to set you up and tell us a little bit more about that.
Yeah, so under the category of getting in touch with your feminine side, this is a little segue for this. If someone is severely injured, we know already that their hormone levels are going to change dramatically. For example, in the case of a man who's had a stroke, his testosterone level will plummet over the next couple of days, and we think that that may be a protective mechanism, actually. So we decided that what we wanted to do was look at these traumatic brain injured patients and look if they had a ventriculostomy, which is a little tube that goes into the brain that drains cerebrospinal fluid to relieve the pressure. We wanted to look at levels in their cerebrospinal fluid and also in their blood and kind of see what's going on there.
Yeah.
Because we were trying to get ready to do an interventional study. And what we found in that study was absolutely incredible. We found that men who had good outcomes actually had high levels of estrogen in their cerebrospinal fluid. So before we go any further, what I want to do is let you know kind of what goes on in normal males and normal females. So you guys who are sitting out here in the audience probably have a estradiol level in your blood of maybe 5 to 15, something like that. You women, depending on how old you are, may have a level from 10 to 40, something like that, depending on where you are in your cycle. But if you look at your cerebrospinal fluid, you only have about 10% there in the cerebrospinal fluid that you actually have in your blood. So men might have a level of 1 to 6 or something like that, and women might have a level of, 2 to 10 or 15. And when we looked at these patients who had severe traumatic brain injury, we were really shocked at what we found. And what we found was that in these men that we looked at who we had cerebrospinal fluid on, that their levels were incredibly high, levels of like 26 to 314 instead of the 1 or 2 to 6 that we would normally expect. And the very interesting thing that we found is that if their levels in their spinal fluid stayed higher than that in their blood over the first 5 days, they did better. They had better outcomes, they went back to work, they led a more normal life. And we found ratios of cerebrospinal fluid levels to blood levels of up to almost 14 times. Instead of being 1/10, in some of these men who did well, we found these levels to be 14 times. However, if we found that their cerebrospinal fluid level of estrogen dropped below that of their blood, they had a bad outcome. They either died or they stayed in a vegetative state.
So Jane, do you have an explanation for why that? So for example, if you got a severe head injury, there might be edema, so it might slow up the flow of hormones to your head, or they don't move out, they're not cleared, so maybe so is this a sequestration of the hormone, like it's kept up there, or are we actually producing more? Do you know the answer to that?
Well, yeah, we thought about that, and we didn't just draw the estrogen levels on these patients. We drew progesterone and testosterone and prolactin, and none of those other hormones built up in the same way that the estrogen did in these patients who did well. So we don't think it was that it couldn't get out. We think it was probably being made. So we went back to the bench and did some cell cultures out of brain cells, and we looked at it, and what we found is that most of these patients have increased pressure in their heads. We know that if somebody hits their head, their brain's going to swell eventually. And what we found is that by applying pressure to these brain cells, that it increased the amount of aromatase that was in their head, which increases estrogen production, which was fascinating. It had never been reported before in the literature.
So this is really interesting stuff. So if you have a bad outcome, your estrogen levels don't go up. If you have a good outcome, somehow you produce more. So we're starting to think, as we call it teleologically, looking back, that nature knows what to do here, and it's good for you. It's good for you to have estrogen up there and you produce it. So even for males and all that. So.
But do you think everyone can produce it? Maybe not,
they may not.
as is evidenced by the patients who didn't do well.
So would it be helpful perhaps to give some to you?
It might be, and we can talk about that in a minute.
So maybe female sex hormones are truly associated with good outcomes, but are they directly protective? What I mean by that is that they could be protective. For example, you're a woman of childbearing age, you got a lot of estrogen floating around, so it kind of protects you from getting into trouble or as deep a trouble as the men. But I'm going to get at, is it actually therapeutic? In other words, if you actually give it to somebody after the fact, whether it's a man or a woman, would you make them better, from whatever insult they had?
Oh, and I think the answer is absolutely yes. And I base that on the fact that over these past 20, 30 years, there have been hundreds, maybe thousands of different studies that have looked at sex steroids in cell cultures and in animals around the world in a whole lot of different models. And all of these point to the fact that all of our sex steroids influence the degree of injury that we sustain and our rate of recovery in many, many different types of injury like transient ischemia and reperfusion. But out of all these studies, the one that the spotlight is really on is estrogen, and that's where the greatest effect has been seen. Because in models of stroke, traumatic brain injury, spinal cord injury, trauma, sepsis, cardiac arrest, you name it, early administration of estrogen has been found to be incredibly protective and has increased survival and has also decreased the ultimate injury by 65%.
Yeah. In some cases, actually, it wasn't just given IV; they gave it other routes, right?
Right.
So, but the thing that seems to be most effective is that IV route. Is that right?
Absolutely,
Okay.
and that's what we're looking at in our models.
Let's give them a good example here. I like this one.
Oh
Here.
yeah, this is a beautiful example. So I'm going to orient you to this slide before I tell you what the effect actually is. So on the left, you see this stack of brain slices, and that's them slicing straight through the rat's brain on both sides. The animal on the left got water, and the animal on the right got estrogen. And then they administered stroke in these animals. And in these pictures, the white area is dead tissue, the red area is good, vibrant tissue. So after 40 minutes of stroke, they administer the water or the estrogen, and you can see that the animal on the right that got estrogen has a nice, more red, more robust looking brain, and the one on the left that got placebo looks really white and really damaged. So you, in a picture, you can see the difference.
Let me reemphasize this. Okay, here you go. You got the rats. You take their middle cerebral artery, the main artery that feeds blood up there, you cut it off, and we're not talking about 4 minutes of permanent brain damage, 5 minutes, 40 minutes later, they infuse this stuff, and look what happens. And it's a dramatic change, et cetera, and that's what's so cool about this. The other thing is that the protective effects of estrogen, sort of as I'm hinting at here, since it's brain, is not cell type or insult specific. In other words, it has anti-inflammatory effects, it's got antioxidant effects, anti-apoptotic, that's the misery loves company, you knock off the cells around you. It has all these effects, but they're conferred in almost every cell in the body. What's really interesting, it doesn't just go to the normal receptor sites like breast tissue or ovaries or something. It goes to every cell in the body. And so what's interesting is the neuroprotective effects are not mediated by those usual estrogen receptors. What we think happens, since it's lipid soluble, as we say, it's like fat soluble, the estrogen not only goes to the cell, but it actually slides inside the cell and goes down to the mitochondria. What's the mitochondria? It's the workhorse, it's the thing where the oxygen is consumed, it's the thing that keeps the cell alive and keeps going. So what we find is that there's what we call upregulation of the mitochondria. Instead of shutting down, because there's no oxygen, it upregulates it. What upregulation means, it keeps it going. It sustains it. It says, keep going, and here's what going. So we think that in every cell of the body, the workhorse is kept going, and that's what makes the difference. And so Jane, do you know how that kind of works? Can you tell us a little bit about that? You do the research there.
Yeah, there are some really other fascinating ways that estrogen works also. Now, don't let your eyes roll back in your head and go to sleep, because I'm not going to make biochemists out of you guys today. But I just want to show you the normal sex steroids. And so you can see the testosterone, which is implicated to be bad for the injured brain, progesterone, which we think may be good for the injured brain, and also estrogen. But if you look at the estrogen molecule really closely, down there where that red ring is, that's actually called a phenol ring. And you've heard of vitamin E being an incredible antioxidant. Well, it is because it has this phenol ring. And what happens is that if you just throw estrogen into solution, it doesn't do anything. But when that estrogen molecule gets into the body, it inserts itself into the lipid bilayer of the cells. And I know I'm going to date myself like I always do, Paul, but anyway, do you all remember those glass tippy ducks that are red that go back and forth, kind of perpetual motion things? Well, that's what the estrogen molecule does. And that phenol ring actually grabs those bad free radicals, those oxidants, and it flips in the lipid bilayer and gets them reduced and gets rid of them and makes them stop doing that. So it's really incredible. It's really important that this works in all the cells of the body, because we know that trauma patients don't just get injured in one place. They get injured all over. So it's really cool.
Okay, well, that tippy duck thing probably does date you a
Yeah.
little bit. The memory thing. I don't know, but I read about it in a history book. So
Oh,
that
good.
kind of
Thank
thing.
you. Thank you.
Actually, either that or you don't remember, because there's two things about getting old, right? One is you lose your memory, right? And then the other thing is the,
Can't remember. Yeah.
Did I tell you about the memory thing?
Yeah.
Actually, you know how you're getting old is you come home and tell your spouse or partner, whomever, honey, I'm having an affair at the office. And he or she goes, really, who's catering it? Okay, so I won't say I know this from personal experience or anything. So anyways, what's the kind of interesting thing is I want to have Jane talk about burns. Okay, this is an interesting thing that really makes our point clear about how it affects. If you take a burn, for example, of the torso, and let's say in a particular case the head's not involved. For example, if you do a study in the laboratory and you just have basically a burn model affecting the torso, those chemicals from that thing go throughout the whole system, but there's not a direct effect on that area. But can the inflammatory processes go in other parts of the body and therefore hurt you? What's the number one reason why people die from burns? It's usually later as the complications of lung failure, okay? But it's a distant organ. Or there's brain, altered mental status occurs. It's at a distant site. So what does this have to do with estrogen? Jane, maybe you can help us out a little bit with that.
Oh yeah, absolutely. We're excited about studying burns at Parkland. You all know the Parkland burn formula. And so we decided to look at estrogen and the effect of estrogen on the burn model. And it was really unbelievable. When we did this, we collected everything in the rats except the squeak. And we looked at all the organs because we only wanted to do the study one time. And what we found was that the biggest surge in inflammation early is actually in the brain, which, as Dr. Pepe said, is far away from the burn. And what we found is that for one of the markers of inflammation, that the animals who got burned, who received estrogen, kept their brain levels of inflammation the same as animals who hadn't been burned at all. And animals who got placebo or water, their inflammatory markers went through the roof in this. So this was a really important finding that we had.
So it was actually, the estrogen actually blocked an effect at a distant site, and it worked in a brain, which is not a typical estrogen receptor site, right?
Absolutely, absolutely.
How about then in the lung? What happened there?
As Dr. Pepe said, the lung is what kills most of our patients that don't die from the initial burn. And what we found was that not only did the estrogen stop the inflammation from happening in the lung. But if you gave a single dose of estrogen to these animals after they were burned, 15 minutes after, that 7 days later, they were protected as far as their pulmonary function. Their oxygen sats were better, their pulmonary function tests were better. It was incredible. 1 dose, 7 days. There are a lot of other things that estrogen does as well. For example, it protects from spinal cord injuries, it decreases the inflammation, the edema, and it increases the function of these animals after they have spinal cord injuries.
And most importantly, it's safe. So one of the things that makes this very attractive is it's safe and it's easy to use. We've actually used it in a lot of things. When estrogen is given all the time. I mean, it's given to men and women all the time. We've had a track record with it for several decades. For example, the first pass effect in the liver is avoided. You know, we've heard about sometimes prothrombotic effects of estrogen. In other words, you get blood clots, or you can get a deep venous DVT, deep venous thrombosis. Well, we think that happens because it goes to the liver and something happens there. But the first pass in the liver, which you usually absorb through your gut, is avoided when you go right to IV. So it's believed to be responsible for that estrogen-mediated prothrombotic effect if you go through the liver first. Here, you're bypassing it and you get it right into it. So we think it's completely safe. And it's been used safely in dysfunctional uterine bleeding. It's been used in uremic hemorrhage. It's been used in advanced prostate cancer, adolescents, etc., and it's been given to both sexes without any complications whatsoever. So it's been a kind of a cool thing.
And it's really cheap. So for example, at a dose at 0.5 milligram per kilogram of Premarin, which is the only IV formulation FDA approved in the US of estrogen, at a dose of 0.5 milligram per kilogram, it's about 100 euros or 135 US dollars. So that's really cheap, especially if you can keep a person out of the ICU for a day.
An ICU day is like $10,000 or something like that. And if you can decrease the number of days people are in there by getting to them early on, or decrease the number of days they stay in there, I think it'd be really terrific, you know, if you think about it. So anyways, the problem right now is that there's a limitation because we haven't done any human studies. There's been a lot of data in the literature, but those basic scientists haven't taken it to the clinical situation. So there's been no human studies of it in acute resuscitation. And we, in our area, we're just tired of seeing rats get resuscitated, and we wanted to move on and start looking at the humans. So Jane, you think that's possible? Could we do that sometime?
Oh, I think it's important. And
Okay.
matter of fact, we put our minds to it, and we're actually doing it at Parkland Hospital right now. We got the FDA to agree to allow us to do this study as exception from informed consent. So we actually give the drug before we consent the patient. And we have the studies called Rescue TBI, which is severe traumatic brain injury, and Rescue Shock that are about 1/3 of the way finished at Parkland Hospital right now.
How's it been? Safe? And so you'd know if there was any complications, right?
Yeah, we've had no unexpected complications, and we're blinded. We don't know if the patient's getting placebo or estrogen, but we've had some miraculous recoveries that we're really excited
Yeah,
about.
I heard a lot of the men basically left the hospital and went out shopping. Is that right?
Oh,
That's
absolutely.
right.
And you know, we're doing it only in men right now.
So it's been good for the economy too, you know, that kind of thing. It's okay.
And their
Actually-
wives and mothers love it. When we go to consent them, they're just so happy that their husband's son got estrogen. They're
Yeah,
hoping
it's
for a
very
shopping
cool. It's
trip.
good. Hey, you know how the economy is getting bad? You find out like the I started on CNN, Beverly Hills mothers and fathers are they're firing their nannies and learning their children's names, so that kind of thing, right? So sorry, I'll stick to my day job. Sorry about that. So I just want to say, Jane's work is now at the top of the queue for the NIH. We just did a renewal application for the Resuscitation Outcomes Consortium. It's a consortium of 10 metropolitan areas in the North America, 3 Canadian and 7 US sites. Unfortunately, we're one of them. It's been going on for several years, and we just got renewed for another 6 years. When they applied, like for the example, the National Institute of Heart, Lung, Blood, whatever, applied to the mothership, NIH, they listed 5 trauma and 5 cardiac arrest studies that they would prioritize, and Jane's on the trauma side were number 1 and 2, looking at TBI and shock. And so she's been congratulated, but it also means that, look at this. I mean, this is considered a priority piece of work for it. And in fact, it's not only going to be useful, we think, in trauma, but hopefully it's going to be shown to be useful in cardiac arrest and all those other things later on. So let's take a glimpse into the future real quickly. What's interesting is that it may very well be, if we prove this is useful, because, you know, it's still $130 and it's not going to be necessarily cheap. We want to say, let's use something that's not going to be effective. So we got to study it. And I actually think you could apply it to a lot of people. Anybody else who you think is going to eventually go to a critical care unit, they should be people who might get this. So we got to study it. But I'm perhaps thinking it's not just estrogen alone, it might be a cocktail of other things. For example, let me tell you, if you were able to start doing this, for example, if you added it with other drugs we'll talk about in a second, like progesterone, cooling, and all those things, I think it could have a great, great global impact. Even if you had a 2% increase in neurological intact survival per day, that would be profound. If we have 1,000 cardiac arrests in the United States done a day and you sent home 2% more people, that's 20 more people going home every day in the United States alone. And that's just from cardiac arrest. We're not talking about the trauma and all those other things. And it could be significant. And Jane, for example, why is this different than, say, brain cooling that we know works? What's the difference between those two things?
Well, it's much easier to give, that's one thing, and it may also work by different mechanisms. And we know that the earlier the intervention, the better the results, and this is something that is able to be gotten on board really early.
And just get on, like for example, you could be in the back of the ambulance, said this guy needs it, boom, you shoot him with it right then and there and get it on board.
See, that's the cool thing about talking to this group. Right now we're doing the study in the ER, but when the ER study's finished, we're going to move it out into the ROC, into the back of the ambulances, and we are excited about you guys participating.
And the cool thing is that, so to speak, with hypothermia is that it actually just shuts everything down. It sort of slows the metabolism down. What you're doing is you're having a direct effect almost on the cells here and not indirect.
On multiple mechanisms,
yeah, exactly.
Absolutely.
So tell us, for example, how this would apply. I just talked about cardiac arrest. Tell us about trauma.
Yeah, absolutely, because even though we've got helmet laws, seatbelt laws, things like that, in the U.S. alone, about 300,000 people are hospitalized for severe traumatic brain injury, and a quarter of those people still die.
And that brings us to another female sex hormones, and that specifically is progesterone for head injury. Very soon, the National Institutes of Health, working with other groups around the world, is going to start the PROTECT trial. And that trial is going to look at progesterone. Now, progesterone is a little bit more difficult to give. You got to give an infusion over several days, etc. But let me show you that it's worked in many ways. They looked at it in head injury cases a few years ago in Atlanta. This was just a feasibility and safety trial. They just wanted to put it on board to see, is it safe? Can it be done? And some of these cases didn't get them for hours. And Jane, how soon do you usually have to give stuff to make a difference here?
Yeah, within 3 to 4 hours for sure.
Yeah, and the biggest profound effect, when does the inflammatory markers really take off?
Oh, the inflammatory markers start at 30 minutes. They're really high.
So that's why EMS may be really applicable here, the bigger, that kind of thing. But here's the deal where they started some cases 10, 11 hours later because they were transferred in from some other places by helicopter. And look at the difference. It's like a 3-fold difference in mortality. On the right, the placebo mortality rate, death rate, was 30% versus like 13% for those that got progesterone. And this wasn't really a focused study, and it wasn't given early in most of the cases.
So this just all fits into your mantra, Dr. Pepe. A milligram of great hospital care can save a kilogram of ICU care.
Obviously, I gave this talk in Europe, so that kind of thing. But the thing of it is that what we really think, based on what Jane just said, is if we give this thing early on, we can make a difference. And I think that's why I'm focusing on you guys and getting you ready, because this may occur fairly soon, which is going to be very cool. So our overall conclusions are that we have now become sex therapists. That's kind of cool. Trust me, I'm a doctor. Yeah, that kind of thing, right? Which is very cool, right? And I just want to, before we leave, I want to go back to that, the remote control thing and talk about when you've been married too long. So what about that remote control? Can you hit it, Maestro? We can play a little video. There we go.
Första servi, trots att det spelar bra, så är ju kanske stoppa problemet av Arsenal mindre än många trodde. Kolo Touré har ju olika alla spilt får det hålla sig till toppkaraktär vidare säsongen. Fint gärna Pires stoppar en 4 i komma mot Swicket. Slår en tidig mot Kanu, Pires!
All right, so anyways, our bottom conclusion here is Jane has coined a new word or term, resuscitative endocrinology, and we, as opposed to reproductive endocrinology, you don't know much about that either, do you? So, okay. But anyways, so we hope that this research will be facilitated and we can take it to the streets sometime soon. And with that, I hope we can help we think that's the secret here, and we hope that it will work on the road to the 22nd century, that we find that the dead shall be raised, and we will make life better for our future generations. Merci. Thank you very much, everyone.
Thank you very much, Dr. Pepe and Dr. Wigginton. That's all we have for you this morning. So remember, exhibit hall, food, bathrooms, and then tomorrow night, the party where Pat Moore will be riding the bull, and I'll be at the controls. So thanks, everyone.